I am Dr. Amit Joshi, consultant and interventional cardiologist working in Bharti Hospital, Sangli. Today we'll speak on the latest updates in hypertension. So, as per WHO, nearly 63% of the total deaths in India are due to the non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% of the people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through the primary care, and there is a poor follow-up. So in India, the prevalence has also gone up over 30 years to 38% in the men and 32% in women from 29 and 28% respectively. So this is the data which is published by World Health Organization, and despite that, nearly half of the people of 51% of the men and 41% of the women with hypertension are unaware of their condition. So this is more alarming. Additionally, more 62% of the men and more than 53% of the women living with hypertension did not get the treatment. So medication was used to control blood pressure in fewer than 1 in 5 and 1 in 4 women respectively with hypertension worldwide, and this data is published in Lancet in this year. International Study Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue, that is resource of poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimal standards of care that allow specification of essential standards of care of low resource setting. So the AHA-ACC guidelines has a scientific statement in 2021, and it has shown that among the patients with low atherosclerotic cardiovascular risk, among those stage 1 hypertension, that is 130 to 139 and 80 by 89, management starts with non-pharmacological therapy. So if the blood pressure remains uncontrolled at 3 to 6 months, then we should consider starting a pharmacological therapy. Acute respiratory distress syndrome is potentially a fatal condition involving lung damage, and experts often correlate it with severe COVID-19. So recent study, which appears to be in the journal of ACC, has reported that the metoprolol can reduce lung inflammation and improve the respiratory function in patients with COVID-19 induced ARDS. Lowering the systolic blood pressure targets down to the 110 to the less than 130 millimeter range that has substantially reduced CV adverse effects in the STEP randomized trial, affirming that the sprint findings for an older Chinese population. Among the 8,500 patients aged between 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk finding from now a second major trial supporting a lower target could unite guidelines which even among US professional societies range from thresholds of 130 to 150 millimeters of mercury. With regards to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension has recommended the diagnosis of hypertension should not only be dependent on office blood pressure measurement, but it should be also out of the office measurements such as ABPM, home BP monitoring, 24-hour and nighttime BP measurements. Those were associated with greater risk of mortality and composite CV outcomes. Thus, they may be considered as the most relevant measurement for estimating the cardiovascular risk. For every 20 by 10 millimeters of mercury increment of blood pressure at night, the risk of the mortality increase by 23% and as well as the CV events by 36%. Most patients with hypertension require lifelong medical therapy to achieve the optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering the high non-adherence to the treatment, the importance of combination treatment is popular and particularly highlighted to improve the adherence therapy as well as the BP control. So, therefore, in 2018 European guidelines recommendation, especially in the context of lower BP target achievement, to start antihypertensive therapy with ideal dual fixed combination of ACE inhibitor or ARB with calcium channel blocker or ACE inhibitor ARB with diuretics. Since early July 2018, the products containing valsartan have been recalled worldwide. The result of the detection of an carcinogen, namely NDMA, the N-nitrosodium methylamine, which can be found in candesartan, irbesartan, losartan as well as olmesartan as well as in valsartan. So it has been classified by the WHO, International Agency for Research for Cancer, as to be carcinogenic in humans. So if 1 lakh people has to be received NDMA contaminated valsartan every day for 6 years, so there can be a 22 additional liver cancer over the lifetime of these patients. The Hygia study represents the largest study that tested nighttime antihypertensive treatment as well as the chemotherapy was associated with significant reduction in endpoints. It has tested the nighttime therapy in comparison to the usual awakening hypertension and it has shown favorable CV risk reduction. The largest study included 19,000 hypertensive patients and the ambulatory BP measurement was performed in around 48 hours to collect data. So the relative risk reduction for CV events was significantly improved for the nighttime treatment when compared to the awakening treatment. So you should remember that the out of the office BP measurement is equally important. The drug combination including valsartan should be carefully added to the patient as well as lifestyle modification should be there for the various group of patients. So these are the newest guidelines and I hope that you should enroll this in the practice. Thank you for the patient listening.